Oh, we're ready. Good evening. It is Monday, October 26, 2020, and I am delighted to introduce you to Dr. Robin Yabroff, Scientific Vice President, right?
Mm-hmm.
Health Services Research at the American Cancer Society. And I know most of us in the breast space think about the American Cancer Society around making strides against breast cancer. But I asked Robin, and I was looking this up the other day, the American Cancer Society started in our country in 1913, 107 years ago. And Robin, just share the core mission of the American Cancer Society and then what your role is with the organization.
Okay. And thank you, Molly. And also thank you for inviting me to this conversation. So the American Cancer Society, as you said, was started more than 100 years ago. And currently the core mission is really to ensure that everyone has the equal opportunity to prevent, diagnose, treat, and survive cancer. A lot of our work is really related to reducing the burden of cancer in the United States. And that means not just the burden of diagnoses, but also premature death due to cancer, as well as the economic burden. And go ahead.
No, you go ahead.
Okay. I was just going to say a lot of my research is related to the economic burden of cancer and what patients and their families experience as a result of a cancer diagnosis. So health services research really means how people receive care related to cancer, or cancer health services research is really about how people receive health care as it relates to cancer. So cancer prevention, cancer screening, diagnosis, treatment, survivorship care, and how that affects their outcomes.
Robin has been a part of numerous research studies presented at both ASCO, the American Society of Clinical Oncology, San Antonio Breast Symposium, and many others where I've heard her speak. And today she sent me something very recent from October 9th from the ASCO, which is, again, the American Society of Clinical Oncology. I'm not a real fan of acronyms. Health-related financial hardship linked with mortality risk, regardless of cancer history. So I thought we would get started right away with that. This paper tells us that there are approximately 17 million cancer survivors who experience lasting effects of both disease and treatment. And compared to individuals without a cancer history, cancer survivors have a greater risk for new cancer and chronic conditions, healthcare costs, including out-of-pocket spending and limitation in amount or kind of work. Now, Robin is a little bit familiar with the Pink Fund. Our primary focus is to provide non-medical financial aid to patients in breast treatment who are out of work. And this is a huge component for patients. Not only are cancer costs high, but when you add in that lost income and it collides with your deductibles and your copays, you're really on the brink of going over a financial cliff. So Robin, share with us a little bit about this report.
Thanks, Molly. I'm happy to. I also want to emphasize before I start about that specific study, the other challenges related to unemployment. It's not just the loss of income, it's also potentially the loss of employer-sponsored health insurance coverage. And this is especially important for anyone who is experiencing any type of illness. My work tends to focus on cancer, but I also think a lot about what's happening with the COVID pandemic right now and the widespread unemployment and also the potential loss of health insurance coverage. So I want to step back a bit and talk about financial hardship. A lot of our research is related to medical financial hardship. And really what that means is having high out-of-pocket costs due to medical care, having trouble paying for medical bills, filing for bankruptcy because of high medical bills, distress and worry about costs, and then also importantly, delaying or foregoing recommended care because it's just too expensive. And increasingly, we see that cancer survivors are more likely to report having high out-of-pocket medical costs, regardless of when they were diagnosed, so even many years after diagnosis and treatment. They're also more likely to report distress and worry and delaying or foregoing care because of cost. So these are common problems for many cancer survivors. And what we did in this particular study is we used data from a nationally representative sample and looked at long-term mortality. We measured medical financial hardship at one point in time, and then followed people over time to look at their risk of death. And what we found was those cancer survivors who reported financial hardship had a higher mortality risk than those who did not. And that was higher than for people without a cancer history. And we found that really striking high mortality risk, even after controlling for things like age and socioeconomic status, gender, educational attainment, geographic region, all of those things we know are so important when it comes to risk of any adverse health event. When we separated the sample into a population aged 18 to 64, and compared to those 65 and over. And the reason we do that separation by age group is because of employment differences in those two age groups, and also access to Medicare, health insurance coverage at age 65. So when we looked at that sample separately by age group, and then we included health insurance coverage type, we found that the magnitude of the association, so that the strength of how high is that additional risk of mortality, was reduced for the population aged 18 to 64, but not for that population age 65 and over. And we think in part that's due to the protective effects of Medicare coverage. So the population, or once people are age 65 and over, they become age eligible for Medicare coverage. And most adults in that age group in the US have Medicare coverage. There's a wide variety of types of coverage that they can have, but most of them have at least the basic Medicare coverage.
So what you're saying then is that group between 18 and 64 may or may not be insured, and whatever type of insurance they have may or may not cover the full cost of their care, or their deductibles will be very high and copays very high.
That's right. That's right. That's right. And there is a lot of variation in the type of health insurance for that younger age group. A number of different types of health plans that have differing premiums, deductibles, co-payments, and co-insurance.
And when you found this risk for higher mortality, years after treatment, was that because patients and their families were still paying off old medical debt?
It could be. We weren't able to look at it in that particular study, but in other research studies that we've done, we have found that the effects of financial hardship can be cumulative. So even if a patient who starts treatment in January, for example, doesn't experience financial hardship, they may by later in the spring, later that year, or maybe several years later, as the effects of income loss due to time away from work, even if they maintain employment, they may take time off from work. Caregivers may take time off from work, and also the additional out-of-pocket expenses. So it could be that builds up over time.
I think there'll be, if they're not started already, a number of studies about what's happened this year in 2020, right? Where patients have been forced out of work, or they are cancer patients and they're immunocompromised and they've self-selected out, and now they're either paying for the COBRA premium, or they can't afford it, or they're going through the ACA. A lot of challenges around kind of a mathematical problem of what insurance should I get and how do I pay for it? Yeah. So the study that you referred to, once you have this data, how is it used to help patients?
Oh, that's a great question. I think making people aware of some of these challenges that patients and their families experience is really important. And when I mean people, I mean providers, all types of providers, including primary care, medical oncology, radiation oncology, surgical oncology, many of the different types of providers that patients know about, but also insurers and health plans, because they, in many cases, are the ones that are creating the health insurance benefit design. It's also important to make employers aware of some of these challenges that patients and their families can experience, because employers frequently make decisions about whether to offer health insurance coverage to their workers, and they also make decisions about whether or not to offer paid sick leave.
Yeah.
Both of those are very important factors related to how people get health care. And, we can come back to the paid sick leave in a minute, but also policymakers, having hard data can be very important for policymakers in thinking about some of the challenges that patients face, especially as we're thinking about how to improve healthcare going forward.
I think a lot about when we talk about earlier mortality because of non-adherence to treatment. We know at the Pink Fund, we had a very small non-scientific study, but our research showed that about 76% of the patients, there were about 595, said they thought about skipping diagnostic tests or treatment. 41% did. Well, the challenge now in our healthcare system, if you blow this up, is that every time somebody doesn't show up, that's lost revenue to the provider, right?
Absolutely.
And so the patient is suffering, the provider is going to suffer. What the provider is going to do the next year when they're putting their budgets together is increase costs. We got it covered for all the about 20% of people who don't show. And they don't show because they either can't afford the deductibles, the co-pays, or they've experienced a loss of income. And probably maybe even a little bit, some people are fearful. But so when I think about the data that the American Cancer Society puts together, this very strong data, that combined with anecdata, with policy, is very, very powerful. Do you ever do some storytelling around patient stories, or do you just present the data?
Oh, I try and do both. I think it's much more compelling if you have a story about someone who's experienced a challenge that you're trying to describe using national data to then describe that story and how that affected them. So for example, having information about people who've lost their homes because they couldn't afford to pay their medical bill is really much more compelling than looking at a couple graphs or some tables with data. I mean, I happen to like it, but I think it's very compelling to provide both. And so I really do try to provide both as much as possible. And then the other thing I want to come back to, I think that increasingly healthcare providers are starting to screen for financial hardship. And I think that's a really important way to begin to address some of these problems. And it may also help with some of the no-show rates that you mentioned earlier. The idea that if you know a patient may be having financial challenges, that it might be better to intervene before they stop showing up for appointments or before they don't take their treatment as recommended rather than afterwards. And, increasingly there are many resources in the community and also other programs that can help patients with financial challenges, such as the Pink Fund.
Yeah, one of the things that's always interesting to me is that the patients are afraid of sharing some of those financial concerns for fear they're not going to get the best treatment. But often the reality is when they do have those discussions and they are screened before their treatment protocol begins, there are ways that you said that the provider and other community resources can step in to mitigate some of these financial hardships so they do adhere to treatment, do not experience earlier mortality, and get through successfully. So when you do your anecdata, when you do your storytelling, do you interview these patients or are these stories that other people share with you?
A little bit of both. We have a couple studies that we've done where we've just asked people to share any of their experiences they would like. And then we can actually use some of those quotes in presenting some of the relevant data. So having a quote from someone who stayed at a lower paying job because they had better health benefits. I mean, that's really important when we think about doing research on something related to what we call job lock, which is exactly what that is that people staying in a job because they have good benefits.
We hear that a lot.
Yeah, it's very common. We did a study that was published in the spring, and I think it was about a third of cancer survivors said either they or their spouse had stayed at a job for health insurance coverage. And yeah, I know. I think, there are other things that people may do as well. They may turn down promotions. They may, there's a number of employment related changes that people can make because of illness.
So let's talk about paid family leave for just a moment. I know that's a political thing, and I believe there's some legislation that's being proposed around that. What we say is that if that burden were removed, knowing that cancer care is longer than 90 days, there would still be long periods of unemployment or lack of income for patients, but this would sort of patch together a little bit of time. So I'm going to skip to a totally different subject, which is our major cancer centers and care in different geographic regions of the country. I know you had a study that you gave me on rural care, and I found that really interesting. But I know you also said you weren't sure you could cite all these things about it, but this starts out that cancer mortality rates are higher in rural versus urban areas in the United States, especially for cancers with effective interventions for prevention, early detection, and treatment. Furthermore, progress in reducing mortality for some cancers has been slower in rural compared with urban areas, resulting in an increasing rural-urban disparity. And a lot of this goes to healthcare, things that behavioral issues. Can we talk about the importance of those things? Because we have a wide variety of people that get on here who live all over the country. So let's talk about that a minute. Some of those healthcare challenges that behavioral changes that we can make on our own.
Yeah. I mean, some of them are behavioral changes and some of them are changes that need to be made in relationship to the medical healthcare system. So, it used to be that in rural areas, mortality rates were lower than in urban areas, but that's switched. And I think a big part of that really is about differences in healthcare and how people use healthcare in different parts of the country. So when we think about rural areas, the employers there are a little bit different. Some of the employers do not offer health insurance coverage to their population. There's higher levels of unemployment in rural areas. There's also higher prevalence of risk factors, so things like smoking in many rural areas. And, as we know, smoking is a risk factor for many different types of cancer. And there are programs that can help in smoking cessation. So, being able to stop smoking or engage in effective strategies to stop smoking is a really important, it's not only for public health, but it also is a cancer prevention strategy. In rural areas, people are less likely to receive screening for cancer.
And why is that?
There's a lot of reasons. And I'll also say that rural areas are really different all over the country. So I have relatives in Eastern Kentucky, and rural Eastern Kentucky is really different than rural Mississippi. And it's also really different than rural Texas along the border or rural California or Iowa. So, rural is pretty heterogeneous. Doesn't mean the same thing everywhere, but there are some challenges related to healthcare infrastructure in rural areas. So there tend to be fewer providers, and there tend to be fewer specialty providers in rural areas. So having access to screening and screening facilities may be a little bit more complicated for people who live in rural areas. Transportation can be a really big one. The challenges of getting to and from centers. And, we have been seeing increases in telemedicine and telehealth, over the past year, especially with the COVID pandemic, and that can help some. But if people don't have access to broadband or they have poor or slow internet connectivity, it's not as helpful as it might be. But telemedicine can help with some of those transportation barriers that patients face.
some of the challenges that you're talking about with telehealth and having broadband and access are some of the challenges that they're having now with virtual schooling in these areas. Where these
Exactly.
families just can't afford it and don't have it, or it's not even available at all. So many of the people in rural areas, I would think, go through the Affordable Care Act. They're probably, I'm thinking farmers, self-employed. Can we talk a little bit about the Affordable Care Act? I know it's coming up on its 10th anniversary. Can we talk about the importance of it, what it covers, what it doesn't cover, and how you see it helping all Americans have at least a choice around healthcare?
Yeah, that's a great question. And I will also say a lot of my research is related to evaluating the effects of the Affordable Care Act. So it's something I think about a lot. So there are a number of different provisions within the Affordable Care Act. One that's especially relevant for cancer patients and survivors is the protection protection against exclusions for pre-existing conditions. And so what I mean by that is it used to be that a cancer patient or a survivor could be denied health insurance coverage because of that condition, or they could have an exorbitantly high premium, or they could have an exorbitantly high premium that would explicitly exclude any cancer treatment from coverage. So that is one of the things that the Affordable Care Act did that's really important, is the protection for people with pre-existing conditions. It also introduced a number of health insurance coverage options. And so we know a lot about the Medicaid expansion. So what that is an expansion of eligibility for Medicaid coverage, which allowed up to 138% of the federal poverty line, which is actually fairly low when you actually calculate what that means. But before the Affordable Care Act, low-income single adults were not eligible for Medicaid coverage in most states, and in states that chose not to expand Medicaid, they're still not eligible. So that's Medicaid expansion is one type of expansion of coverage options. There's also the dependent coverage expansion, which allows young adults to remain on their private health insurance, their parents' private health insurance coverage up until age 26. And then there's also the marketplace, which allows people to purchase individual options. And I think that's one of the provisions that I think is especially relevant for people who are self-employed, who previously were not able to purchase health insurance coverage as part of a group, which is what most people do through their employer.
And if you lost your job and you had COBRA and it could go on for 18 months, but you didn't have another job, after that, what happened if there wasn't the Affordable Care Act? You were uninsured, you had to go, what did you do? You had to buy private insurance?
You could apply for an individual policy, but you could be turned down for that policy, or you could have specific types of care not covered, or you could be uninsured. Or if you were income eligible, you might be able to enroll in Medicaid. But yeah, especially I think for I think one of the population groups that I think has been really helped a lot by the Affordable Care Act is single men.
Oh,
yeah.
Tell us more about that. There are, by the way, about 1,800 men get diagnosed with breast cancer every year. Again, men don't think they're going to get breast cancer, right? So they feel something and think it's a pimple.
Yeah.
Why is it? Tell us more about the single men.
Yeah. So, well, previously, before the ACA, in many states, men were not eligible for Medicaid coverage. Even if they were low income, they still were not eligible. And so, and if you're self-employed, you may have had fewer health insurance coverage options, especially if you didn't have a spouse that you could then get insurance coverage through as a family option. So
knowing all this, how do you, I mean, I know you're not in the business of advising patients, but people come to the American Cancer Society for advice. What does one do? Where can we go on the site? What do you share with us, how we can help patients?
Oh, that's a great question. So American Cancer Society is a great source of information for patients and also for caregivers and families. And you can simply use search terms based on the type of cancer or the type of question you might have. There are also telephone, where you can call. I think it's 24/7 if you have questions about a specific type of care or service. There are a number of other organizations as well. So for example, the National Cancer Institute also has a number of resources available for cancer patients and their families. One of the things people tend to ask about a lot is treatment options and how do they make decisions about treatment options and understanding sort of the risks and benefits of those different treatment options. And I include the cost of those treatment options in that calculus as well. And so those are questions that are great for providers. Tell me more about, if you're a cancer patient thinking about your treatment options, knowing more about the possible benefits and also adverse effects of all of those treatment options. Things like, will I be able to work during treatment? If not, when can I return to work?
How can I schedule my treatment so it doesn't interrupt my work as much?
Exactly. Are there ways I can schedule my treatment? Or this is the type of job I do. And how will that affect my treatment, or how will that treatment affect my job? Those are all really important things to know. And I have a colleague who frequently tells a story of a breast cancer patient who drove a school bus for children. And, knowing that was the schedule, she was then able to schedule her chemotherapy for Friday afternoon as opposed to Monday morning. And that's a really important thing for a provider to know, that allowed that breast cancer patient to continue working.
So that's really interesting, because one of the first people we helped was a female bus driver, and she was most concerned about the scheduling, but also concerned about the effects of neuropathy and the shift the bus. And what about surgery and lymphedema, all some of the side effects of mastectomy that might impede her ability to continue with that work? Would she have to change jobs altogether?
Right. And then, other things, different insurance plans cover different types of treatments differently. So for example, there are some breast cancer treatments that are relatively similar, but depending on the type of health insurance coverage you have, one might be dramatically less expensive for you compared to a patient who has a different type of health insurance coverage. And so, those are the types of things that providers can help patients with as well, especially if they have that information to work with.
Well, I want to talk a little bit about, because you just brought something up around making those decisions around your coverage and your treatment. We're entering the last quarter of the year. We're actually in it. People are making decisions about their health care. Either they're going to stay with their employer, or they're going to elect whatever plans the employer provides. How do you suggest that a person who's not high on health literacy make an intelligent decision about insurance design?
Yeah, it is really complicated. And I think the first thing is how many options are available. So some, depending on health plans or whether you're buying health insurance through the exchange, there may be some options that you can narrow it down to and then make some comparisons. But the key things to be comparing are the premiums, which are the monthly amount you pay, the deductible, which is the amount that must be paid before any coverage begins. And increasingly, there are plans, they're called high deductible health insurance plans, which have lower premiums, but then the deductible can be very, very high. And that can be a difficult situation. On the positive side, there are also things like health savings accounts that are frequently partnered with high deductible health plans that allow people to put money away pre-tax to help pay for healthcare. Other things to consider are co-payments, that's the flat rate that people pay for different types of coverage, and co-insurance, which is a percentage of the list price that people will have to pay out of pocket. So there's a lot of different things to think about. And it can be very complicated. And I will say, I study this for a living. And sometimes I'm a little bit stymied about what to do with my health insurance. But the main thing I think about for me is ideally, I want to have as many options as possible. And I also, personally, I tend to favor paying a little bit more higher premium, that monthly amount, to make sure I have other options and that I don't have really high co-insurance in case I do have a high spending event during the year. Those are the things I think about. Yeah.
That is great advice. And guess what? It's 6 o'clock. Can you believe it?
That went so fast.
I know. Dr. Yabroff, thank you so much for joining us. We will make sure that some of these research studies that we alluded to that are complex and fascinating, but take some time to digest, will be available. And this segment on Facebook Live will be available not only on our Pink Funds Facebook page, but also on our YouTube channel. And finally, I want to thank Exact Sciences, the maker of the Oncotype DX test, and Cologuard for underwriting this series. So thank you, Dr. Yabroff. Happy Monday. Have a great week.